Okay, well, thanks very much. I'll start by thanking the organisers for inviting me here. It's lovely to be back in Scandinavia this time of year with the very long days. I'm here to talk about the European guidelines for the management of newborn RDS syndrome. And what I'm hoping is in the next 30 minutes to give yourselves some of the understanding about some of the controversies which are still there in RDS care. When I talk to you about how the European guidelines are formatted, hopefully you'll gain some insights into guideline preparation using grade methodology. And then we can discuss some of the current recommendations in the most recent European guideline, and hopefully from your feedback this will help inform how the next guideline might be formulated, because it's always in a constant state of evolution. This slide I put up not because any of you need educated about what RDS is. We all know that RDS is a disease of mainly preterm infants, which presents after birth with increasing respiratory distress caused by lack of alveolar surfactant. And the natural course, if it's left unmanaged, is that babies may die or they will naturally recover after about 3 to 4 days. It's got described as having classical X-ray appearances of brown glass with air bronchograms. But nowadays, with modern neonatal care, we almost never see babies who are allowed to get very severe hyaline membrane disease. And in fact, most babies are currently even treated with surfactant before the first X-ray is done. Also, it's worth pointing out that it's very hard for us with modern neonatal care to really get a handle on defining RDS. If you look at the returns from Europe for Vermont Oxford from 2015, for babies less than 29 weeks, about 90% of them are coded as having RDS. Whereas if you look at the control arms from randomized trials of CPAP versus surfactant, we can see that only about 50 or 60% of babies end up being treated with surfactant. So what's actually probably happening is that people are treating babies with suspected RDS and then coding them as having RDS. And for that reason, it's sometimes difficult to be exactly sure about what's going on. Why do we need guidelines? Well, we all know how to manage RDS. We've been doing this for the last 30 years. We know that babies with RDS benefit from prenatal steroids. We know that they need support with oxygen, non-invasive respiratory support, sometimes mechanical ventilation. And we've had surfactant therapy around for almost 25 years now. And we know that babies need good supportive care. But if you think carefully about it, many of the things that we do, although they're life-saving, some of them, like for example mechanical ventilation, can cause harms such as damaging the lungs and increasing the risk of BPD. And thankfully many of the interventions that we currently use in newborn care have been subjected to randomized controlled trials. So the purpose of the RDS guidelines is to try and look at all the information we get from randomized trials and try and make some sensible recommendations for what we believe the clinicians should be doing. And when making these guidelines, we try and use the grade methodology. So if we make statements about what we think people ought to be trying to do, then you can grade the strength of the evidence supporting those recommendations. So grade A evidence would be coming from high quality randomized controlled trials or meta-analysis of randomized trials. Grade B would be from smaller randomized trials. Grade C would be case control or cohort studies. Grade D would be just expert opinion. And in addition to grading the strength of evidence, you can also grade the strength of the recommendation. So if you strongly believe that this is what people should be doing, then it's a grade 1 recommendation. If there's still an element of doubt about whether it's correct or not because research hasn't been done, then you can give it sort of a qualified recommendation by saying it's grade 2. So hopefully as we go through the talk, you'll see, if you see the letters and numbers after the recommendations, you'll know what the guidelines group are trying to communicate. So the guidelines group was convened to discuss controversies in RDS management and try and examine the evidence for best practice. The process was endorsed by the European Association of Perinatal Medicine. The group was first convened in 2005. The first guidelines were published in 2007, and they've since been updated 3 times in 2010, 2013, most recently 2016. So the guidelines I'm going to talk today are based on evidence up to the beginning of 2016. So there's some things that are currently hot topics which may not yet be in the European guideline. The guidelines group is made up of 10 neonatologists from 10 different European countries, and this is the current guidelines group here. And you can see most of them are grey-haired men. I'm actually not one of the experts. I was invited along at the start to be the scribe, to write down the ideas of all these professors, and have been involved since then, but I can't actually claim to be qualified in terms of having done any significant research myself, other than just doing the work of writing the guidelines. So today we're going to discuss what's changed over the years and to highlight some of the recent evidence which has informed the opinion in the most recent guideline. So the guidelines are quite extensive, and today I've been briefed to try and talk about early respiratory care, really within the delivery suite in the first moments of life for preterm babies. So I'm not going to try and cover the entire guideline, but we can see they do begin before birth. They go through delivery room, surfactant, oxygen, and invasive, non-invasive mechanical ventilation. So beginning before birth, what as neonatologists might we expect our obstetric colleagues to be doing? We're working alongside them. Firstly, there's a recommendation that mothers who are going to deliver babies less than about 28 to 30 weeks gestation should be moved to large perinatal centres with a high throughput of very low birth weight babies. There's evidence from cohort studies that outcomes are better for babies if they're born in larger centres with a high throughput. If mums present with threatened preterm labour, they should be offered a single course of steroids if they present before 30 weeks gestation. There's clear evidence that steroids will reduce mortality from RDS. They've changed the wording in the most recent guideline to from when the pregnancy is considered viable, because in previous guidelines we'd said from about 24 weeks, but nowadays we look after babies of 23 weeks gestation, so it's reasonable to offer non-steroids at 22 weeks, even though there's not much evidence from randomized controlled trials very specifically in that gestational age group. If the mother hasn't delivered after a first course of steroids, there is evidence that a second course of steroids, if the mother presents again before 34 weeks, will further reduce respiratory morbidity. So there's a recommendation that we should use a second course, but the strength of recommendation is maybe slightly stronger because there hasn't been an awful lot of long-term follow-up data looking at the effects of repeat courses of steroids on the developing brain. We can also consider prenatal steroids for mums who are going to be delivered by caesarean section right up to term, but we shouldn't use the steroids as an excuse to do deliveries for mums for spurious reasons before 39 weeks gestation. And we can use steroids in late preterms if there's no chorioamnionitis, but again, there's much less evidence to support this. So moving on then to our approach to delivery room stabilisation for the baby at risk of RDS. So what sort of considerations do you think people would be thinking about? There's obviously the timing of cord clamping, how much oxygen should we be planning to give these babies, the issue of sustained inflation, are there a group of babies that should be routinely intubated, what sort of monitoring should we employ in the delivery room? Well, I don't want to get into too much detail about everything there because there's quite a lot. Essentially, right from the beginning in 2007, we've been recommending doing delayed cord clamping because of the Cochrane review showing the benefits in terms of improving blood pressure and reducing IVH. In terms of the question about how much oxygen we should use for preterm babies, there has been a bit of research done over the last 3 years in terms of trying to determine what produces the best outcome. It's clear that in term babies, if you use air rather than 100% oxygen, the outcome is improved. There have been several small studies of preterm babies trying to determine whether you start higher or lower with oxygen and whether you get a better outcome. And one example of one such study is here by Capadia, published 2013, where babies are randomized starting at 100% oxygen and then titrating down according to saturations, or starting in room air and titrating up. And what tends to happen in all of these studies, if you start high, you tend to oversaturate and you work down, and if you start low, they tend to be a little bit more hypoxic, and then as you work over the first few minutes after birth, they all tend to end up about the same, at about 30 to 40% oxygen. The babies in whom have been started high in those studies where they have measured markers of oxidative stress, you can see that there are increased markers of oxidative stress. But does this equate to any important differences in terms of outcome? Well, there has been a meta-analysis by OE published in the Archives 2016 where they've taken all of these studies and tried to put them together to try and make some sense of what's happening in terms of clinical outcome. And at present, there's no clear difference in any major outcome in babies less than 29 weeks if they've been randomized to high or low oxygen. The confidence intervals are quite high, so consistent with either significant benefit or harm. One of the things that they did point out that if the very tiniest babies are randomized to room air, there was a trend towards increased mortality. So for this reason, the current European guideline is recommending starting oxygen at about 30% for the smallest babies whenever planning for stabilisation. What about the issue of sustained inflation? A number of years ago, there was a study from the Netherlands, which was quite small, but seemed to show that a sustained inflation rather than repeated inflations after birth seemed to reduce the need for mechanical ventilation and potentially improve respiratory outcome with reduction in BPD. Since then, there have been a couple of randomized controlled trials and then subjected to meta-analysis in Cochrane 2015. And at present, there's no strong evidence supporting the use of sustained inflation, although further studies are currently underway, such as the SAIL trial. So at present, there's no recommendation for routinely doing sustained inflation, but as more evidence becomes available, that may change. So if we come to the summary of the delivery room recommendations, start by saying we should delay cord clamping by at least 60 seconds. The strength of evidence, we used to say grade A because of Cochrane review, but when you look at the individual trials in the Cochrane review, they're actually babies that are a little bit more mature than the ones we're currently thinking about for RDS, so we've downgraded that to B, and hopefully the results of the Australian placental transfusion study, which is about to publish in the next few months, which randomized 1,600 babies less than 30 weeks, will give us a more definitive answer. If we can't do delayed cord clamping because of cesarean section, etc., then cord milking is a reasonable alternative to delayed cord clamping. When planning stabilisation, we should aim to use about 30% oxygen for babies less than 28 weeks gestation. For more mature babies, maybe slightly less than that, 21 to 30%, and guide the oxygen levels using pulse oximetry in the delivery room. If babies are spontaneously breathing, and most of them with RDS are because they're not asphyxiated when they're born, we should aim to use CPAP with a pressure of at least 6 centimeters of water via face mask or prongs. And if the baby's not breathing, then we should use gentle lung inflations with a controlled PIP of about 20 to 25 centimeters of water. Intubation should be reserved for babies who've not responded to the above measures, and we shouldn't be prophylactically intubating tiny babies. But babies who do require intubation should be given surfactant. And we should do all of the stabilisation with the baby inside a plastic bag under a radiant warmer in order to prevent heat loss.
May I
Yes.
ask you a question about
Sure.
this? Has the CPAP pressure been randomized? 6 centimeters, 5 centimeters, 8 centimeters?
No, I'm not aware of any trials specifically looking at that, but I think what we have is data from studies where CPAP has been used, and I think there's been a range up to about 8, and I think what we've said here is at least 6 centimeters rather than specifically saying a PEEP of a particular value. So if you want to use 7 or 8.
In the recommendation there is 8 centimeters, there is 8 centimeters given as a number as well. But we graded it as A1 evidence in the full paper. Where does this evidence come from to say 6 to 8?
I think
because it's quite fancy for me using the grading system and coming up with these numbers.
Yeah. Perhaps we could tease that out at the end rather than now, and I'm sort of conscious if we need to get through the rest of the talk, but we'll have some time at the end. We can maybe discuss that. Okay, so next up, the issue of surfactants. So the sort of considerations for surfactant therapy. Are there any babies that should be getting prophylaxis? If we're going to give surfactant, how should we give it? What preparation should we use? When should we treat with surfactant if we aren't using prophylaxis? And then there's the issue of whether babies should be sedated or not for surfactant therapy. So in the 2007 and 2010 guideline, we were saying that babies less than 28 weeks and then less than 26 weeks should be receiving prophylactic surfactant. Then in 2012, there was a Cochrane review of the more recent studies, which had been specifically designed to address the issue of whether prophylactic surfactant was still necessary in the current era of CPAP use. And in this Rojas-Reyes meta-analysis, you can see that there's a small but statistically significant difference in terms of the outcome, death or chronic lung disease, favouring the control arm being babies that are initiated on CPAP and not given prophylactic surfactant. So since 2010, the recommendations have been trying to steer people away from doing routine surfactant prophylaxis, but rather using a policy of early rescue surfactant. And as much as possible, we've been trying to encourage people to use the insure technique where possible. So that's the technique where babies who are on CPAP and needing surfactant are given surfactant as a bolus through the ET tube, followed by immediate extubation back to CPAP. And there's been a Cochrane review, and the authors is from Sweden. Mats Blennow is the second author of this paper. You can see if you plan to use insure, you will reduce the need for mechanical ventilation. You'll reduce early, and you'll reduce the outcome of chronic lung disease at 28 days. So until recently, we've been suggesting maximising the use of the insure method where possible. But more recently, in the last number of years, there's been an explosion in work looking at the use of what's called less invasive or minimally invasive surfactant, where the surfactant is delivered to spontaneously breathing babies using a fine catheter, which is placed in the trachea while the baby's still on CPAP. The first evidence from this came from the German neonatal network, who published their outcomes before and after implementation of this policy in 2015, and they seemed to show much less reduced need for mechanical ventilation and reduction in the outcome of BPD. In 2015, the German network also published a randomized controlled trial of 211 babies comparing this new technique with conventional ventilation via conventional surfactant administration followed by mechanical ventilation. And in this randomized trial, they weren't able to demonstrate any increase in survival without BPD, but they did show some improvements in survival without serious adverse events. And at the same time, there was another randomized trial of 200 babies from Turkey, which directly compared this new method with the old insure technique. And in this study, they seemed to show a reduction in the outcome of chronic lung disease from 20% to 10%, although the study wasn't powered to look at that outcome. So again, just to show you briefly, the German cohort study, you can see babies from around 25 to 28 weeks. There seemed to be in the time period after implementation of this less invasive surfactant, much less need for mechanical ventilation. And you can see there's also in this cohort of babies around 24 to 28 weeks, there was less chronic lung disease. Again, this is an observational study rather than a randomized controlled trial. And there was a meta-analysis published 2014 with the studies that have been done up to that point, showing us that by that time there was no strong evidence that it was definitely better, and that all the outcome of BPD among survivors was not yet proven. In other words, although the technique of using the catheter seemed to work okay, it was not necessarily proven that it was better than the insure technique. So it's evolving, this area, and there's been since the European guideline published 2016, there's been another meta-analysis of 6 randomized controlled trials published in the European Journal of Pediatrics, and it shows us that the minimally invasive surfactant method does seem to reduce the rate of CPAP failure, and also with a statistically significant reduction in the outcome of death or BPD. And at the same time, there's early clinical trials underway looking at whether surfactant nebulization will be a reasonable alternative to a mode of getting surfactant in a minimally invasive way. So I think this is an evolving area, and hopefully there'll be more in the next guidelines published. What What about which surfactant preparation? Well, I think everybody agrees that natural surfactants are superior to synthetic. There's some work recently showing that synthetic surfactants with addition of peptides may be performing just as well, but that's really in its early stages. There have been comparative trials among the different surfactant preparations, and there's been a recent Cochrane review published 2012 looking at all of these randomized trials. And most of the studies show that these natural surfactants are broadly equivalent. In the Cochrane review, the only forest plot which shows any difference at all is one where poractant alpha or Curasurf, when used at a dose of 200 per kilo, is compared to Beractant or Savanta at 100 per kilo, and there's a slight difference in the outcome of death or BPD. And for this reason, the European Guidelines Group is recommending that if you're using Curasurf, that you should use it in a higher dose of 200 per kilo. In terms of timing of surfactant therapy, there's a bit of there's a dilemma for neonatologists, because if you aren't using prophylaxis, there's good evidence that you get the best outcome if you don't intubate at all. However, there's also good evidence that if you need surfactant, the earlier you use it, the better the outcome. And you can see from the earlier Cochrane reviews of early versus late surfactant treatment that this is the outcome of any early. You can see that if you use surfactant earlier, you reduce the risk of pneumothoraces. You can also see if you use surfactant earlier that you reduce the outcome of chronic lung disease or death. So it's important, I suppose, that we pick a threshold for when we should intervene with surfactant, and typically the FiO2 of more than 30% is what the European Guidelines Group has been recommending. And that number was largely picked out of the air by consensus, but there is some evidence to support the use of 30%, which has come about more recently from Peter Darwin's group. He was preparing for the Optimist trial, and he wanted to see which group of babies should be randomized into Optimist. And from within his unit, he had 297 babies who were born less than 32 weeks, and he looked at ones who had CPAP success versus CPAP failure. And he was able to show that the babies who had CPAP failure, you could predict the CPAP failure by the highest FiO2 in the first hours of life. And he was able to show that an FiO2 of 30% was a reasonable predictive test for CPAP failure by 6 hours of age. So I think it's still reasonable for us to suggest for the smallest babies that we pick a number of 30% as a way of determining when they should be treated with surfactant. So to summarize then the surfactant recommendations, babies with RDS should be given a natural surfactant. A policy of early rescue should be standard, but there are occasions when surfactant should be given in the delivery room, such as the extremely preterm babies whose mums haven't had steroids, or those who require intubation for stabilisation. Babies with RDS should be given surfactant early in the course of disease, and they've suggested a cut-off of 30% FiO2 for those less than 26 weeks, and maybe 40% for those above 26 weeks. And poractant alpha in a dose of 200 per kilo is better than 100 per kilo of poractant alpha or Beractant if you're using surfactant as rescue. We should consider minimally invasive surfactant methods such as Insure, LISA, or MIST if the infant is breathing spontaneously on CPAP. So the group have got around this issue of the catheter method by saying, pick whichever one you like. If you like doing it, then go ahead. And if a baby's got ongoing evidence of RDS, then we should use a second and sometimes even a third dose of surfactant. In terms of beyond stabilisation, what saturation should we choose? Well, there's been a lot of work in this area, a lot of controversial work, but the current recommendations are that we should, once the baby's stabilised, target their saturations to sit between 90 and 94 by putting the pulse oximeter alarm limits at about 89 to 95. And there is a section in the guidelines covering non-invasive respiratory support. So there's all sorts of different ways of providing non-invasive support now. Various ways of delivering CPAP. There's nasal ventilation, which consists of both BiPAP and synchronized NIPV via ventilator. And then more recently, there's been an explosion in the work on heated humidified high flow nasal cannula. I think one of the talks later on in this meeting is about that. What can we say about NIPV versus CPAP? Well, I'm not expecting you to read this slide because it's very complicated, but if you look at the Cochrane review from 2014 and you tease out the important findings from it, you can see in terms of reducing the risk of extubation failure, if you use nasal ventilation delivered by a ventilator, then you will reduce the risk of needing reventilated. But if you use the bi-level CPAP devices, which are currently quite commonly used in neonatal intensive care units, there's not much evidence that it makes an awful lot of difference. And in terms of improving outcome, chronic lung disease, in the Cochrane review, if you use synchronized nasal ventilation delivered by a ventilator, the studies that have been done do suggest a reduction in chronic lung disease. But if you use the bi-level CPAP devices, there's no signal in terms of improving outcome. So BiPAP is fine to use if you like, but there's no strong evidence that it does that much in terms of improving outcome. If you are going to use nasal ventilation, you probably should be doing it with a ventilator and trying to synchronize it where possible. And then in the terms of high flow, without getting into too much detail, there has been a Cochrane review published 2016 looking at all the studies where babies were randomized to high flow versus CPAP. And when you tease out the meta-analysis, you can see this is treatment failure within 7 days of trial entry. This is dividing the babies into those less than 28 weeks, those 28 to 32 weeks, and then greater than 32 weeks. And you can see at each of the gestational age bands, there's no strong evidence that one is better than the other, although it must be said that in the meta-analysis there were relatively few babies in the very immature group, and I think most clinicians wouldn't be as comfortable with putting very tiny babies on high flow compared to CPAP. So for non-invasive support, the recommendation is we should start CPAP in all babies at risk of RDS who don't need intubation for stabilisation. The system delivering CPAP is of little importance. However, the interface should be short binasal prongs or mask, and we should use a starting pressure of at least 6 centimeters of water. And CPAP with early rescue surfactant should be considered the optimal management of babies with RDS. Synchronized NIPV, if delivered through a ventilator rather than a BiPAP device, can reduce extubation failure and may reduce BPD. And high-flow nasal cannula may be used as an alternative to CPAP for some babies during the weaning phase. So a little bit vague, but it allows people to adopt those practices in their units in terms of if that's what they choose to do, and there is some evidence to support it. What about mechanical ventilation strategies? Well, a lot of the guideline is about trying to keep babies off ventilators and trying to minimize the duration of mechanical ventilation. So as much as possible, we should be adopting techniques to keep these tiny babies off ventilators as much as possible, or keeping them on the ventilators for a shorter duration as possible. And obviously caffeine is an important consideration in this regard. Most of the data that we have about caffeine comes from it's now 10 years old, the CAP trial. And we all know the CAP trial was not a prophylactic caffeine study, but a study on babies who were showing signs of apnea of prematurity, or babies who were coming off mechanical ventilation. And babies who were randomized to caffeine came off the ventilator a week earlier, came off CPAP a week earlier, came out of oxygen a week earlier, and had less BPD. And then the follow-up of the CAP study, which was the main outcome, was the safety data showed that babies who were treated with caffeine early on had less death or disability, less cerebral palsy, and less risk of cognitive delay. So caffeine has become a very important drug to use in perinatal care. And from the beginning of the guideline, we've been suggesting we should be using caffeine almost very routinely. But that's not strictly evidence-based, because prophylactic caffeine hasn't really been studied in great depth. People have tried to address this by looking at cohort studies where babies treated early with caffeine are compared to babies treated later with caffeine. And here's one such study by Dobson, published in 2014. He had a large database of 62,000 babies. He He was able to pick those from the database who were less than 1,500 grams, who hadn't died in the first 3 days, and who had received caffeine. And using propensity score matching, he had a large database of 29,000 babies from whom he was able to examine the relationship between those treated with caffeine earlier in their course before day 3 and after day 3. You can see in this study, it's not a randomized trial, but you can see they're well matched for gestation, weight, and their maximum FiO2 on day 1. But those that were treated early with caffeine have less risk of death or BPD, less ROP, less PDA, less IVH. So again, it's not strong evidence in terms of grade A, but it definitely gives us some reassurance that if we use caffeine early, it's probably not doing any harm. And in terms of mode of ventilation, sometimes we do have to ventilate babies. The best mode of ventilation at present is probably volume ventilation. There's a Cochrane review which compares the outcomes of studies where babies have been randomized to volume ventilation versus pressure limited ventilation, showing a reduction in the risk of death or chronic lung disease. There's also been a Cochrane review on HFOV versus conventional ventilation, showing a slightly improved outcome for HFOV as well. So whichever mode you like to use in your unit, I think you can use it, but if you're going to use pressure limited time cycle, then targeting tidal volume will probably improve the outcome. So for strategies for mechanical ventilation, after stabilisation, we should only use ventilation when other modes of respiratory support have failed and the duration should be minimised. We should use targeted tidal volume where possible, and we should avoid hypercarbia as well as severe hypercarbia, as these are associated with increased risk of brain injury. And when weaning from mechanical ventilation, it's reasonable to tolerate a modest degree of hypercarbia. We should use caffeine to facilitate weaning from mechanical ventilation, and early caffeine should be considered for all babies at risk of needing mechanical ventilation, such as those less than 1250 grams birth weight who are managing a non-invasive support. And babies who get stuck on mechanical ventilation, a short tapering course of low-dose dexamethasone should be considered to facilitate extubation in those who remain on mechanical ventilation after 1 to 2 weeks. In the future, hopefully, this is some work from Henrik Berder's group in Denmark. They've developed a device which can measure the lecithin sphincter-myelin ratio, looking for surfactant in gastric aspirates. So maybe in future we'll have a bedside test which will individually be able to predict which babies are likely to fail or succeed on CPAP. And again, I think this over the next coming years we might see more work in this area. So I'll stop there. Thank you very much.